Everyone, thank you for joining us, and apologies about being a few minutes late. Welcome, happy Friday, and happy holiday weekend. I'm just going to share my screen so we can just walk through the advisory that will be coming out, and this will basically just take the place of our medical providers' notes this week. And this advisory is really just a chance for us to just share just a bunch of different topics and updates with you. So hopefully you could see that. And let me just make that a little bit bigger. Okay, can you guys see the 3-page advisory? I know it's hard to read. I'm going to blow it up. Okay, hopefully you can see that. Let me know if you don't. And we're going to be emailing you as well. So this will be just something that you should get in your email imminently. So we continue to be severely impacted, and we didn't even include that in this advisory. Although I'm happy to loop back and share with you the many metrics that the hospitals are working through. Hospitals are at record levels in terms of COVID and non-COVID volumes. And really, I did my media session today and this didn't come up, but I think our medical community needs to know that we are just really at the margin of going into crisis care standards. And we're already doing the preparatory work to do that, because it does take quite a lot of coordination to implement getting that right, just because it's a recognition that resources are extremely short, needs are extremely tall, and just trying to match needs and resources in a way that's equitable, fair, and really consistent across a complicated population, which the hospitalized patients obviously are. So all of that is already going on at every single hospital. These committees are meeting. I think everyone else just needs to understand that there are just some severe constraints at the hospitals. I know you know that, and that's why I'm not going to belabor that. And you can look at our dashboard if you want to look at the data. The other question that we are fielding a lot is, when is this surge going to end? And our models that the state is sharing with us indicate that we still have a couple of more weeks at least, and maybe even 4 to 6 weeks at worst for this surge persisting. And the surge, you can define that as positivity rate, case transmission in the community, hospitalizations, or ICU hospitalizations. And they all relate to each other, but they all have a slightly different timing. So that's why, 2 to 4 weeks of severe strain across the healthcare system and severe disruptions across what we can offer to our sickest patients, our highest acuity patients, is what we can expect. And Fresno County, being part of the San Joaquin Valley region, is kind of, in my opinion, the county that's most severely impacted in the whole state. It's because we are the receiving center, we have the trauma center, we have all of the other resources that our surrounding neighboring counties rely on to transfer patients. And while other areas of the state seem to be emerging from their surge already, which is so irritating, but that's what they're doing. Southern California, Northern California, Bay Area, they're actually plateauing, and in some cases, their numbers look great. They're actually coming down. Their hospitals are still full, obviously, and they're not really able to help load level or level load, or whatever you want to call it, by accepting our patients. But they seem to be emerging from their surge. And so there is a glimmer of hope that the state as a whole will emerge from this surge by mid-September. But unfortunately, the metrics still look pretty grim for Fresno County. And so we're just, A, still going to continue to struggle. B, there's no other resources readily coming from the state, even though we are definitely trying to get that to happen. So we are kind of stuck on our own until things get better. Now, I'm using all of that as a preamble to say there are things that we can all do as a medical community and that we all need to be doing as a medical community. And that's kind of why we crafted this health advisory, is to let people know this is the stuff that we can control, and this is what we really do need to try to work on. And obviously public health is happy to support you in whatever way you need. But the first item that we're going to talk about is monoclonal antibodies. There's still a myth out there and a misperception that this is hard, that this is only for hospitalized patients, that this is some exotic procedure that you need a lot of training to do. And I would submit that none of those is true, that this is really just another medication that you can provide through a quick IV infusion, or even a subcutaneous shot. So in the same way that you give heparin or insulin subcutaneously, you can also do monoclonal antibodies. The reason that these are important is because they actually will help some, but not all of your COVID patients stay out of the hospital. So you do have to give them very early in the first 7 to 10 days after they get COVID symptoms, or you can actually give them even if the person is in a state of quarantine and they're just a close contact, and that's called post-exposure prophylaxis. So they don't have COVID infection yet, but they're so high risk that they're going to have a really bad outcome if they do get positive for COVID. So you can just go preemptively strike and give them monoclonal antibodies to protect them. So it's kind of a cool technology, and you need to know about it because I think we really need more providers doing this. You've heard me say this for several weeks in a row, and that's for a reason. It's because we're really underutilizing it, in my opinion. It does require an investment of time, and reading this advisory is the best way that you can, in about 20 minutes, figure out exactly what you need to do. So we link to this advisory that Dr. Zweifler and some of our other colleagues worked on. It's a great document. Please look at it. If you do need to refer people to colleagues that are already doing this, this has a list of those clinics as well, although there's only a handful at this time, and we're just not doing it enough. And if we did more, then we could perhaps decompress our hospitals. So that's the reason that I bring this up, is that if we catch these people early, we may be able to keep them out of the hospital if we were doing monoclonal antibodies. We're actually crafting an order that will allow a medical assistant under the supervision of a physician to be able to administer these antibodies. So another barrier that we heard from you was that you don't have enough nurses to do this. Well, now you don't need a nurse. You just need a supervising physician and some health professional who's trained in starting IVs or who's trained to inject medications. And it could be the same people that have been giving vaccines in your clinic. It could be someone that's just had that training. So figure this out using whatever resources you have, because I think it will help your patient population. It might even help your staff. We hear about staff being out with COVID. You know what? Some of them would qualify to get monoclonal antibodies and be able to come back to work that much faster. So think about using this as a way to protect your own staff, protect your patients. And I think if we have more use of monoclonal antibodies, that it would really pay off. It is free. You do have to register with the manufacturer, and they want you to orient. And so there is a little bit of a delay with that, but we can work through that. We can help you. We can actually get you some starter kits, as it were, to get you started right away if you're interested and ready to start. But then you can kind of start getting your own supply shipped directly to you from the manufacturer. All of that is included in this advisory. Any questions about that topic before we move on? All right, so the next item that I think is going to be very relevant to your practice is that testing is kind of bottlenecked right now. There's a lot of reasons for that, but the biggest reason is that the rapid antigen tests are no longer available from the state. They've actually paused that supply due to, I guess, federal national issues related to supply shortages. So at the state level, they're not sending things down to the county levels. And at the county level, unfortunately, we're not able to fulfill a lot of the requests for these antigen tests, the Binax antigen cards. And if you go to the CVS, you'll see the empty, it's a really beautiful display that Binax created because they're charging $25 for 2 tests. And so they're making a lot of money on this, but they're sold out. So, I'm sure even if you go to CVS, you're going to be hard pressed to find these because people have kind of grabbed them. And unfortunately, we just can't rely on rapid antigen testing right now until the state is able to secure more supply. So work with the testing task force. The testing task force website is really great. They have good information on how to do PCR testing, how to get started. They will link you up with vendors. They will show you how to swab your own patients and send out your test yourself. All of that can be done. And so your one-stop shop for testing needs is the testing task force website. It's really well done. It's probably the best website that the state's made in the whole COVID pandemic. We also have a testing website, and this will point you to the local testing sites that are offering COVID tests. As you can imagine, those sites are in high demand as well. So just take that as a caveat that if you are referring patients to OptumServe or to any of the pharmacies right now, that they're just inundated with requests as well. It's just a really hard time because we know testing needs to be done during a surge, but unfortunately we're running up against a lot of bottlenecks related to even PCR testing. So you should anticipate that and prepare for it by trying to track down and really working in parallel streams, in my opinion, and working with several different vendors to make sure that you have a good supply chain. We're hearing that tests are getting done, and 60% of tests are getting done within 24 hours, even with the PCR. So that's really good. It's not the nightmare scenario that we had in the early months of the pandemic, but we understand that this is a hardship, and we'll try to support you as much as we can, but we're all kind of working under these hardship conditions right now. The third item, which is kind of interesting, is if you have TB patients. I think the original advice was to hold off on COVID vaccination. Well, the new advice that just came out yesterday, the CDC is saying, don't let anything delay COVID vaccination. If you have a TB workup going on, if you're doing a skin test for TB, or if the person has active TB and they're not that sick, don't let any of that stuff delay COVID vaccination. And we're just sharing the CDC's advisory on that at this link. There's also a PDF letter that's like a dear colleague letter from the CDC that we can share with you as well. The next item is the flu order. So as you know, flu season is right around the corner. You should really be prepared to do your annual flu clinic and get those procedures dusted off and ready to go. You're going to be hearing from your vendors that they're going to be able to send you flu vaccines if you haven't heard already. Usually the pharmacies get them first, but regardless, the clinics will get them eventually and public health kind of gets them last. But either way, all of that is right around the corner. And so we've crafted our flu order for the year, and that's listed at this hyperlink at the bottom of this item. The question has come up, what's the badge color? The badge color technically this year is turquoise. I never really understood the badge concept, and I don't feel that strongly that you absolutely have to have a badge program. As long as you can just document that your staff is vaccinated and that you're offering flu vaccinations for people, that's really the important part of this. So let us know if there's some piece of this mandate that you're not able to meet, and we can work with you. We're flexible on that. The other obviously big question is about exemptions. And I would say we're going to be using the same exemptions policy for both the flu and the COVID vaccination, which means that if somebody has a legitimate medical exemption or a sincere religious belief that precludes them from being vaccinated, then those would be the two major reasons for exemption, but that has to be really well documented. And in an ordinary year, that person who is not vaccinated against the flu would be forced to wear a mask throughout the flu season. Well, guess what? Everyone's wearing a mask all the time now. So that's a little bit of a moot point, but maybe you could think of another creative way to punish them. I'm just kidding. Maybe work around that. I'm not sure, exactly how to address people that refuse to get flu vaccinations. I think they put themselves at extraordinary risk. They put the organization and your patients at an extraordinary risk. And so they really just need to understand and be educated about how important it is to get the flu shot. And obviously it is FDA approved. So they should feel very confident that it's a reliable product. Speaking of vaccines, please push vaccines. Continue to offer vaccines. This is really the highest yield intervention that we can make for this pandemic of COVID, and frankly for flu. And so we really just need to get vaccines to our patients and lower the barriers. And that means, if they come in with any other complaint, at least have that conversation with them and really try to meet them wherever they are on the spectrum of vaccination. And if they're hesitating or skeptical or have a specific question, please take the time to answer and then look them straight in the eye and say, please, you need to get your vaccine. It's really important. I'm telling you, as your medical health professional, this is a really big priority for you to get your vaccine to keep you and your family safe. And I think when they hear that from multiple different professionals, especially during a patient encounter, that's very powerful. For immunocompromised individuals, remember those are eligible for a third dose now. And for wasted, we've also fielded questions about what if you have leftover doses at the end of a day. So I just put this in here. I just said wasted doses are strongly discouraged. So please use any leftover doses as appropriate to eligible individuals. Eligible individuals mean people that aren't yet vaccinated, people that are immunocompromised, and even if you can't find people that fit in those first two categories, people who are ready to get their booster, which is really something that they should be ready for 6 to 8 months after their last shot. So I just put approximately 8 months to give you a little bit of wiggle room, but between now and September 20th, it would just be a shame to waste doses, because we know that on September 20th is when boosters are going to go live, as it were. And, in all likelihood, there will be a dash and there will be high demand. And so we might as well just preempt that and just start doing boosters now for people that are approaching 6 to 8 months, especially the 8-month mark. And that's why I just put this in here with as much wiggle room as I could give you to allow you to start doing boosters now for people that are appropriate to do based on their timing, and also for leftover or wasted doses that would otherwise end up in the wastebasket. It's much better to start on boosters with those doses. So hopefully that makes sense. You're going to hear more about the official dogmatic rollout of boosters as soon as the state figures out how involved they want to be with boosters. And then we'll be able to explain to you, what the plan is for mass vaccination sites, whether the state is going to just use their My Turn app to just allow a lot more booster capacity through that network in area pharmacies and other clinics that are doing vaccines right now. There's a lot of unanswered questions. And frankly, the vast majority of our time is spent on addressing the surge at the hospitals, but we are spending a little bit of time thinking about boosters and talking about boosters with the state. So you'll be hearing between now and September 20th, a lot about boosters for Pfizer and Moderna. For now, if you have the logistics and the capacity to do boosters, you can go ahead and get started with doses that were otherwise destined to go in the wastebasket. I think what you should do right now is figure out how many of your folks are going to be interested in boosters and when they will be scheduled at their 8-month mark. That way you have a good idea of how much you need to do if you are planning to offer booster shots and you have that capacity. If not, then basically it will give you an idea of how to schedule your folks out so that you can make sure they get their booster when their 8 months comes up. For some people, it'll be in September, and that's the people that got their second dose in January. For other people, it'll be October, November, December, just depending on when their 8-month mark lands. And so, this will be kind of a months-long rollout among our healthcare workers and among our general population. But it will start, towards the end of September. We're already in September, so it's just a couple of weeks away. And hopefully we'll have a little bit more clarity about how to do booster shots because we haven't heard anything definite there's just a lot of kind of preparatory groundwork and information gathering going on between the counties and the state right now. And we've heard nothing about Johnson & Johnson. So, that's another question people have is, what about Johnson & Johnson patients? Are they still protected? Do they need boosters? What if they're immunocompromised? Right now, the answer is still wait for more information. We're going to get announcements from CDC, FDA about how to approach Johnson & Johnson patients. For now, the single Johnson & Johnson shot should be protective for those patients. Any questions about those items? I know that's a lot of info. Okay, the last item is kind of an interesting one because it's on the surface doesn't seem to relate to COVID. And the reason that I added this in here is to just recognize that there is just a tremendous amount of strain on people's mental health right now. In the general public, in the healthcare staff and workforce. And I think that that is actually leading to people having risky behaviors. Especially, we're seeing a lot more overdoses. We're seeing a lot more presentations related to alcohol abuse. We're coming up on a holiday weekend. And I think that we really do need to take time to think through how we can support our community related to their mental health. So one easy thing we can do is for patients that are at risk of opioid overdose, offer them naloxone. That's actually the law. If you have a patient who is getting high doses of prescription opioids or is at risk because they've disclosed to you that they are using street drugs that have opioids, then really the law says you need to talk to them about Narcan and offer them a prescription of naloxone. Well, we can actually do better than that and actually give them naloxone to go home with. And again, with the pandemic creating the amount of mental stress that it is, it's no surprise that 2020 was the deadliest year on record for opioids. Nationally, 93,000 people died of opioids in 2020. And that's 30% higher than it was the year before. So this is a huge epidemic. It's still going on. Although on the surface, it seems unrelated to COVID, I think it actually is very related. And that these are behaviors and risks that people are unfortunately taking as a coping mechanism. So I think we need to be sensitive to that. I don't claim to have all the answers, but I know naloxone works. I know it saves lives only if it's accessible to patients at the time that they need it. And that's why take-home naloxone makes so much sense. Well, we actually just got a box of take-home naloxone, a big box of 36 units that we're ready to hand out at the health department. We're doing this at area hospitals as well, including CRMC, Clovis, and several of the mental health clinics that the behavioral health department oversees. So this is something that is available and that you need to know about. It's actually something that you can start doing yourself. It's a 2-page application. We've linked the link here for you. So if you're interested or if you serve a lot of patients that are at risk, you really should have naloxone on site that you just hand to people, no questions asked. And that's exactly what the point of this grant is. It's a low barrier naloxone distribution grant. So please look into it and make sure that your patients have that going home, and make sure that you counsel them about what it is, how to use it. It's actually an intranasal device, so it's actually very easy to use, and really try to refer them to some of the behavioral health clinics that can help them with their opioid use addiction or their substance use disorder if they're struggling with alcohol or other drugs. The last thing that you can do, which also takes 5 minutes, is get your X waiver. So if you have a DEA license, it'll take 5 minutes to get your X waiver. It's really that simple. I've been able to do it with several of my ED colleagues, and I've actually even done it over a Zoom. So maybe in future sessions when this surge ends, we'll devote a little bit more time to what the X waiver is, and maybe even just get some of you registered over Zoom because it's not hard to do. But once you get your X waiver, you can start prescribing Suboxone. Suboxone is the real answer for opioids. This is the prescription that will prevent people from having cravings. it will actually treat withdrawal, and it will actually get them stabilized to the point where they can actually repair their lives and get on the road to recovery. We've had a lot of good outcomes just using Suboxone, even out of our emergency department. And this is just a national change in practice. None of us learned this in medical school. And so that's why it seems exotic and scary. It's really not. It's a very simple process, and it's very new, but it's something we all need to know about, especially those of us that are doing emergency medicine, urgent care, primary care, or prevention at any level. So I know that it's new, and there's always the fear of the unknown, but trust me, getting the X waiver is so easy now, and starting people on Suboxone is something that anyone on this call can do after just a little bit of coaching and training. Take care of yourselves. This is a really stressful time. We had a call with the state with, all of the counties in the San Joaquin Valley, and so many of the hospitals and county personnel talked about the extreme fatigue that they're witnessing and the mental health crises that they're witnessing in the patient population. And so I think that this is a real unmet need right now. And that's why I just wanted to add this to the end of our advisory, is to say this is something else that we should really be focusing on. And we need more creative solutions and more strategies that could help people. So again, if you have some suggestions or recommendations, we'd love to hear them. If you want to know more about any of these topics, then reach out. I'm happy to have a conversation. I think that that's the end of the advisory. So look for this, and Sim actually is on the call, and he could probably advise when it's coming out. But I think it's ready to go, and we'll try to push it out later today, and we'll publish it online too. Any questions or anything else that you want to cover? I'll look in the chat. Looks like a big shout out to St. Agnes. Thank you, St. Agnes. We know you've been doing monoclonals for many months now, and we really appreciate it. Something's available on Amazon for 20 bucks. I'm assuming that that's the, I don't know, Bobby put that in there. I'm assuming that those are the Binax antigen cards. That's great if they come. I can imagine that you click that yellow button and then they tell you, oh, wait 6 weeks because we're back ordered. So, but yeah, use whatever means you have at your disposal to get testing supplies for your patients. Any other comments? All right, good question. So we are planning on having a flu and COVID vaccination clinic. Is a provider on site required for this event? So that's a good question. Typically with flu clinics, I don't see that a provider is required to be on site. And I think even with COVID vaccination clinics, there's not necessarily a mandate that a provider has to be there. I do think you should have a process in place to observe people just in case they have an adverse reaction. But, maybe we were just too cavalier with flu. I remember just walking in on the way to lunch and just getting a flu shot and then just going about my day and not even worrying about the observation time. With COVID, I think because the vaccine is so new, there's a lot more caution with that. And because it's a 2-shot vaccine, maybe the second shot will create a little bit more of a reaction. So I would say just, have that observation time maintained whenever you do the COVID part of the vaccination. But I don't know that a provider is required to be on site as long as you have a policy and procedure that explains what's going to happen if there's a medical emergency that, the staff need to respond to. So I would just say have a policy and procedure that recognizes that, there is an observation time and that there are staff that are trained to respond to common and anticipated adverse reactions to either vaccination. But that brings up another great point, Naomi, which is that you can offer flu and COVID on the same day at the same time. So I'm sure that's another question you're going to get from your staff is, can you get flu and COVID vaccines on the same day? The answer is yes, you can. Okay, if the COVID rapid test is positive, are we still sending the PCR out to the lab because of the variant? That's a great question, Lupe. You actually don't need to. If you have a positive rapid antigen test, I would just treat that as a positive COVID. I wouldn't necessarily spend time doing a PCR on a patient. If they were negative but symptomatic, and I really sensed that it was COVID, then I might send a PCR just to confirm and make sure that, that we get a more reliable test. But if you have a positive on the rapid, I would just treat it as a positive. You don't necessarily need to send a PCR, especially during this time when our testing supplies are at such a premium that you don't need to be redundant. In terms of the variant testing, that's hard to accomplish even when you want it. At this time, the state is doing high level surveillance with just a sample of all of the tests that they receive. And so you don't necessarily need to check for the variant in any specific patient. You can basically bet money that it's the Delta variant. I mean, that's what more than 90% of these variants are now whenever they're checked in California. So, until we hear differently from the state, the variant testing isn't really going to add value to your workup, whether that's a hospitalized patient, an outpatient, or you're just doing screening for some reason. The variant doesn't really change any of the management. And so you don't necessarily need to send off variant analysis. Obviously with hospitalized patients, with outbreak clusters, and with other special cases, especially those that are immunocompromised or have received monoclonal antibodies, those are special, unique cases where variant analysis is actually quite useful. But for the ordinary general community patient, where you're just trying to ask a yes/no question, you don't necessarily need to do variant testing for those cases. Any other questions? What is the minimum time interval for the COVID booster? I would say 6 months. I think I haven't seen anything that shows immunity wanes earlier than 6 months. For immunocompromised patients, they're on a different schedule and they just need to get the third dose as early as like 1 month after their after their second shot. So I'm talking about non-immunocompromised patients. I would say they would need a booster no earlier than 6 months and ideally at 8 months. I think that's kind of where the science is landing, although it's still an evolving topic. Medical assist. Okay, so Dr. Z, feel free to speak up if you want, Dr. Z, but he just added a just a clarification. So medical assistants providing vaccine need to have their clinical supervisor on site. LVNs need to have a standing order. RNs can administer independently. I don't know if you want to add more to that, John, or if you're addressing someone's specific question about that. Is that just the policy and procedure?
Yeah, so there seems like there's some questions about that. So, yeah.
Great. Yeah, so, medical assistants, we know that they can take a very short course to certify for IV starts. They are required to take a course to help get them trained to do vaccines. And so we feel like between those two trainings that we could craft an order, which, because we're in a surge, because we're in an emergency, because staffing is so short in our county, we feel that we have a path forward to craft an order that will allow medical assistants under the supervision of a physician to do the monoclonal antibodies. So that's kind of what we're crafting. Again, we need to have some conversations with county council, which we are planning to have next week to make that order get passed. In the meantime, if you need something to help you do that process with your medical assistance, then reach out to us and we can craft a memo or a statement to help support you individually. But that's kind of where we're going with that. Okay, well, I think we will adjourn if there's no other questions or comments. Thank you all so much. Have a restful and relaxing Labor Day weekend. You've certainly earned it. So make sure you carve out some time to just decompress and take care of yourselves and reach out to us if we can help with anything else. In the meantime, check your email for this advisory that should be coming out later this afternoon. Thank you. Have a great holiday weekend.